overview of pulmonary respiratory disease. After that, we'll present a local perspective by Dr. Yogi, Masters in Cardiopulmonary and heading our pulmonary rehab sleep, which is our center taking care of outpatient respiratory patients with comprehensive rehab. And then, time permitting, we have a panel discussion for other issues in India. And we can wind up all this in a reasonable time that you are both entertained, happy with the academic discussions, and at the same time, the gastronomics allow people to go for a decent dinner later. So, pleasure in welcoming Dr. Sally Singh. And in the interest of time, all the people who've logged on, the YouTubers, Dr. Sally Singh, the podium is all yours.
and breathless because they have a respiratory disease. So it's a really challenging problem to unpick. Now, you probably know all of the management strategies better than I do, but clearly the priorities, or indeed innovative, entrepreneurs who've developed packages to manage COPD, for us to engage in that. Now, the evidence for that is a bit flaky, and clearly there is a suggestion that they're not cost effective either. So I think that until we have better evidence, we need to be careful about purchasing expensive telehealth interventions. And you can see here, this is data from European colleagues, where the distribution of these interventions is skewed compared to the value that they present. And you might argue that this is, partly influenced by pharmaceutical companies encouraging people to have triple therapy. It's a shame they don't encourage people to have pulmonary rehab at the same, but that's life, isn't it? Now, it's a global priority to provide rehabilitation, but very specifically, the World Health Organization also identified that COPD was key to their agenda to provide rehabilitation for non-communicable diseases. And in fact, last year, I was fortunate enough to be involved in a development of their information packs, which they called a package of information for rehabilitation, that focuses specifically on the management of cardiac and respiratory disease. And this advice is meant to be rather ubiquitous, so anybody in any country, in any environment, can actually use the information that's available. Some of it is quite sophisticated, the level of equipment you need, and when we started rehab, we certainly had a lot less equipment than they're suggesting in this document. So I think some of it, there's a bit of flex around that. Now, the American Thoracic Society a couple of years ago had a workshop that involved people from all around the world, and these were the priorities that they set for low and middle income countries. Now, I'm not going to go through all of them because I suspect you would certainly guess most of them. I'm just highlighting that pulmonary rehabilitation was an important point that needs to be addressed globally. But it also identifies that it should be adapted, cost-effective, and broadly culturally appropriate, and we'll come back to that. Chronic respiratory disease that is individually tailored to their needs, with the absolute aim of optimizing somebody's physical, social, and psychological well-being and their level of independence. And importantly, programs comprise individual exercise programs and a package of self-management education in terms of moderating the symptom burden associated with the disease. Now, just before COVID, Anne Holland and I chaired an American Thoracic Society workshop looking at what the key components of rehabilitation are. And some of you may have taken part in this Delphi process. We try to make it international. It's never quite as international as you want it to be, but hopefully there was some engagement from people in India. And after a couple of rounds of the Delphi, there were the key areas identified that you can see on the right-hand side. And we broke those down into patient assessment, program components, the method of delivery, and then a process of quality assurance. So the patient assessment is critical. We're now at a point where there's a lot of rhetoric around exercise is medicine. And if we are going to do rehabilitation properly, we have to treat exercise like a medicine. So we have to assess somebody's exercise capacity and prescribe it and progress it as you would with any pharmaceutical management. So the initial assessment has to include a measure of exercise capacity, then measures of quality of life, breathlessness, nutritional status, and occupational status. The program content fundamentally has to comprise endurance training and resistance training that is individually prescribed and progressed, importantly. And the team has to have experience in that. There has to be an element of training for staff to deliver that program. Now, what you will notice, and I think we were slightly ahead of our time in some ways, because this just happened pre-COVID, and of course COVID turned the world upside down in terms of how we provided services. This was broadly location agnostic, so we didn't say it has to be in a centre, a hospital or a village hall or a religious hall or online. But these, however you deliver it, these are the key components that you have to tick off. And then ideally there should be a process of quality assurance. And I was lucky enough to set up an accreditation scheme for pulmonary rehabilitation through the Royal College of Physicians back in the UK. So in the UK we have one, America there's one, but I don't think any other countries do. So there's a real opportunity there as well for you. Now, the aim of rehabilitation is, as we've heard, to improve exercise capacity and reduce the burden of disease symptoms. Now, this graphic is taken from a fairly old editorial in the New England Journal of Medicine, but it actually summarises the mechanisms of action for pulmonary rehabilitation. We start at the top. Because people are exercising in a room with healthcare professionals that aren't frightened of people getting breathless, then people become desensitised to the sensation. I always used to joke, if I got £1 for every time I'd say to somebody, you're not going to die if you get breathless, I could have retired quite a long time ago and I'd have been quite rich. So it also decreases people's levels of anxiety and depression because they're in a group environment supported by healthcare professionals. There's some evidence to suggest that the exercise training reduces dynamic hyperinflation, and importantly, it improves skeletal muscle function. So this is where the deconditioning comes in, that I suspect broadly applies to all of us in this room. So if we can improve people's skeletal muscle function, we reduce their ventilatory requirements because the muscle is more efficient at dealing with the oxygen that is delivered. What you won't do is alter people's lung function. COPD have a fixed airway dysfunction, and you will not change people's spirometry by lung function. And I think a lot of people think that we can, and we can't. You can make people fitter and improve their exercise tolerance through these mechanisms, but you will not alter their lung function. So I would dissuade all of you from asking how effective rehabilitation is and how much you've changed somebody's spirometry, because if their pharmaceutical management is optimal, you should not be altering their FEV1 with rehab. So that is a really important message. So these are the key components of rehabilitation. This is our rehab programme in Leicester, in the hospital. There's an absolute dearth of equipment. We're sort of equipment light, so I would suggest this sort of thing can be replicated globally with minimal cost. Our programme focuses on aerobic walking that is individually prescribed and progressed. And that's because in the UK, walking is a really important activity to people. That's what they want to be able to do. And you can also carry on with that after you've graduated from a rehabilitation programme. If you make it too fancy with lots of gym equipment, what are people going to do after they've left the programme? So you have to think of that transition and how you are going to encourage a permanent change in lifestyle. And then there's the resistance training that, you know, we've got small hand weights, but you could use milk bottles full of sand or water to do at home. And then there's the educational component that largely comprises these sorts of topics that have gone a bit squiffy, haven't they? But breathing control, exercise, anxiety management, medication management, exacerbation management. How do you know when things are getting worse? So just to clarify on a very broader scale, GOLD recommends pulmonary rehabilitation and have said that there is grade A evidence for rehabilitation. So this is absolutely something that we should all be offering because there's a very strong evidence base. Now, Gold identified this from the Cochrane review. Now, this review was published in 2015 and concluded that there was compelling evidence for the benefits of pulmonary rehabilitation. And in fact, we don't need any more randomised controlled trials. Now, I would caveat that and say we don't need any more randomised controlled trials in high-income countries. I think the challenge is very different, and there is value in doing research and working out the best way of delivering rehab. And that's essentially what they're saying here, that there are some nuances around the delivery that we all need to pay attention to in terms of the ideal length, location, supervision, etc., which does lend itself to home-based rehabilitation programs. Maintenance is really difficult to establish, and the sort of optimal maintenance strategy has not yet been established. Now, we also know that rehabilitation works irrespective of an individual's disease severity. So we classically identify patients for pulmonary rehab using the MRC dyspnea scale, and we would use the criteria 2 to 5. Historically, people have been very anxious about referring people that are considered to be MRC grade 5 because they think they're too severe. But you can see this graph simply identifies improvement in exercise capacity across grades 2, 3, 4 and 5, 5 being the most severe. So these patients think they're breathless, well, think they are. They report they're breathless when they're dressing or undressing, so really the severe end of the spectrum. But you can see that the improvements you get in the walking capacity is no different across the range of MRC grades. So don't be discouraged from referring really very severe patients. We've had patients through that perceive that they are wheelchair bound, and then at the end of rehabilitation they're able to walk, not for miles, but they are much more independent and not dependent on a wheelchair. There is also evidence in other chronic respiratory diseases. There's a Cochrane review in asthma, interstitial lung disease, bronchiectasis, and I'm going to talk a little bit later about tuberculosis, where I think there's growing interest in rehabilitation for post-TB lung disease. So the American Thoracic Society recently published their evidence-based guidelines, which were clearly based on a series of PICO questions. And the questions obviously are predefined as you go in to do the analysis based on some of the Cochrane reviews that have been published post 2015, and really being sensitive to the needs of the American insurance companies. So it's slightly political, slightly academic, as always. But you can see that just running down the questions, clear evidence that people with stable COPD should take part in rehabilitation. Acute exacerbation, post-acute exacerbation, they should take part. NICE have done a review to suggest that the evidence would point to a reduction in hospitalisation, so there's a strong clinical and economic argument for doing post-exacerbation rehabilitation in the COPD population. We don't know about other respiratory diseases. ILD, pulmonary hypertension. Also suggested that taking the research evidence, but does it work in real life? People will say you've got very select populations who really want to do it, and where are we in terms of generally offering it out to the masses? Now, this is data from our pulmonary rehabilitation audit that is supported by the Royal College of Physicians in the UK. We have a minimum data set which helps us define the quality of rehabilitation across England and Wales. It allows us to benchmark, and it allows us to support quality improvement projects where we learn from the good centres that are doing things really well, and we will share that and have a good practice repository. So you can see from this graphic that 78% achieved a minimum clinically important difference in at least one of the measures. And the two measures that are on this graphic are walking and health-related quality of life. So two key outcomes for pulmonary rehabilitation. It also has an impact on admission rates, and our healthcare system is organised slightly differently to yours, but the NHS is desperate to keep people out of hospital, and that is a really key driver for us. And you can see that this data shows that those people that complete rehabilitation are less likely to be readmitted than those that don't. And also the number of bed days is shorter, so that if you've completed rehab, your symptom management is better, you're probably fitter going into hospital than you might otherwise have been, and so you have less hospital days even if you are admitted. Now, we've talked about the pandemic, and we were all forced to do things very differently. Largely everything went online. And rehabilitation was no different. And it was a little bit like the Wild West. Everybody was doing something different and just broadly hoping for the best. And obviously everybody had the best of intentions. But I think now is the time to reflect and secure a little bit more evidence to understand what we're doing. So we've got to the point where for home-based rehabilitation there was limited evidence and limited guidance. But there's a huge potential to look at hybrid-based programs, home-based programs that don't rely on any technology, so manual-based. You can look at video conferencing, or you can look at much more independent activities using digital interfaces. Now, a moment ago I said that the ATS strongly recommended telehealth. The British Thoracic Society were slightly lukewarm about it, and this is a problem with the type of analysis that happens in a Cochrane review with your forest plots where you're comparing two different interventions, because although they say they are equivalent, arguably they could be equivalently bad or equivalently good. So you need to treat these Cochrane reviews sometimes with a little bit of caution. So in the UK, we plotted the data from the systematic review that looked at telehealth that supported the claim in the ATS statements. Now, these are studies that use the 6-minute walking test as their primary outcome, and the dotted line represents the minimum clinically important difference. Now, you can see that most studies fall comfortably below that line, but each group were about the same. So home-based is the same as centre-based, but both are largely falling under the line. So the BTS recommendation was treat with caution and really as a priority offer people centre-based rehabilitation before you consider alternatives, because we really have very strong evidence that we know that that works. On the right-hand side, we have the 6-minute walking test data from the McCarthy Cochrane review, and then on the very right-hand side is our national audit data, which exceeds all of the trial data again. And this is just a trial, just to make the point. This was a video conferencing trial that was conducted, I'm going to say Norway or Sweden, but one of the Northern European countries. Now, if you look on the left-hand side, you can see that they are equivalent, but nothing has happened in terms of the 6-minute walking test to both groups. The other interesting thing is, before we all think that telehealth or digital options are the next best thing, you can see the number of people that declined the opportunity to take part in a digital intervention because they wanted to come and have that contact with their peers or healthcare professionals for which intervention. And clearly there are lots of questions outstanding. These are some of the questions that were identified in the ATS statement, and you can see that they talk about pulmonary rehab for low and middle income countries, which is something we'll get onto in a moment, looking at culturally adapted models of rehab, and then looking at tele-rehab in non-COPD and after exacerbation. So although I've been in this game for years, there is still a lot to do, and more than a lifetime's worth of research. So let's look and see what's happening in low and middle income countries. So this is a culmination of data from a couple of reviews and our Recharge project, where we've just plotted where we have been working with teams in the sort of brightly coloured lungs, and the black dots represent existing trials that have been reported. You can see that largely the most trials come from either Turkey or Brazil. Very few trials genuinely from lower middle income countries or low income countries. They're largely upper middle income countries. And we have been working as part of our Recharge project, which has been funded by our National Institute of Health. We've been working in 3 centres in India, a couple of centres in Sri Lanka, 1 in Kyrgyzstan, 1 in the DR. And this is a summary of the data. Now, the red dots indicate a high risk of bias, and the majority of studies were observational, so not randomized controlled trials, so they're poor quality and not randomized. So, you know, there's not a lot of data for you to all think, right, this is what I need to do. But lots of opportunity to develop high quality rehabilitation programs. So as part of the Recharge project, one of the things we started, and we talked about this a lot today in cardiac rehab, that you can set up the best rehabilitation program in the world, but if you don't get any referrals, it sort of doesn't matter. Nobody's going to come. So you have to educate the referrers. So one of the first things we did was survey people. So this is data from Pune, which I'm sure you'll all know is not a million miles away from here. So we asked referrers what influenced their practice around referring into a pulmonary rehabilitation program. Well, depressingly, most people didn't have enough knowledge about pulmonary rehabilitation. So there's a real challenge there for all of you that have an interest to advocate for rehabilitation and educate all of your colleagues. Then there's some sort of practical issues about lack of time for referral, don't know what the process is, and unaware how to refer. And then we have this sort of really depressing box at the bottom, is I'm uncertain that pulmonary rehab is worthwhile. So, you know, and this is people that refer into pulmonary rehab. So this would have been respiratory physicians, respiratory nurses, respiratory physiotherapists. So there is a lot of work to be done in terms of advocating. On the flip side, when we looked at what would influence a patient to take part, you can see that, unsurprisingly, it's all around managing breathlessness, shortness of breath, low exercise tolerance. So I don't think that comes as any surprise, and actually what the patients are telling us is a direct match to what we deliver in rehabilitation programs. So in Pune, we had to really twist what we were going to do very quickly, because COVID hit. We were going to do this supervised rehabilitation program, and obviously that all went horribly wrong because it was COVID. So all of a sudden we went from, no, not going to do a centre-based program, we're going to do a digital program. So we spent, well, I say we, the team down in Pune spent a lot of time talking to patients and their families about what good looked like with a digital intervention. And one of the things that really came through very strongly was yoga. Now, I'm sure you can all understand that, and I've learned a huge amount about yoga in the last 4 or 5 years, and it's obviously a very complicated intervention. So we picked out the bits of yoga that would complement the evidence base around pulmonary rehabilitation. So we had an app that integrated aerobic walking with elements of yoga to improve breathing control, anxiety management, balance, etc. And so developed the app that looks like this. So it's available in English, Hindi and Marathi. And patients can directly access their healthcare professional through the app, but it does not require you as a healthcare professional to be logging in all the time. It's a very light touch app, and obviously that gives it scalability to a certain extent, because you can manage arguably many more people on a digital intervention than you might be able to on a centre-based program. So we conducted a feasibility trial, and this is just the sort of edited highlights that I'm going to share at NAPCON, and Shruti's beavering away writing up the paper. But you can see that looking at the MRC score, the mean MRC was 4, so a fairly severe group of patients. We didn't cherry pick the sort of more able patients that you might assume would be more digitally active. In fact, we had, I think it was 3 people that were illiterate. So within the app, there is a lot of video content that people that are illiterate or can't read or write very well can follow. We looked at health-related quality of life, anxiety and depression, and functional capacity, and you can see that all of the measures improved. Now, we haven't put any p-values in there because this was feasibility, so technically you're not allowed to put a p-value in, but I'm just pointing out that all of the changes were highly positive and improved beyond the minimum clinically important difference. And graphically, that's what it looks like. I've just highlighted the incremental shuttle score and the EQ5D score, which would ultimately allow us to put an economic value on this as well. But you can see that the anxiety and depression score go down, whereas the other two scores go up. But that's a good thing, that that's gone down. And then Rashmi did some qualitative interviews, and patients were terribly enthusiastic about it. And one of the interesting things that struck me that we don't see in the UK is the importance of family. And one of the beauties of this digital intervention that I'm not sure any of us expected was how the family got so involved with it, because they didn't need to be at the centre at 3 o'clock on a Wednesday afternoon, and really their children would rather have been at work or had to be at work. So they sort of embraced it, and it became a family event really, because not all of the people that we recruited were digitally active. So I'm just going to spend the last few minutes talking about TB. Now, just after the publication of the American Thoracic Society evidence-based study, there is a challenge around providing a rehabilitation program in this post-TB population. We know that there are all sorts of residual respiratory disabilities and a significant symptom burden. So compared to normal healthy controls, people have reduced exercise capacity, increased breathlessness, and abnormal lung function. So pulmonary rehab may be a really important intervention because logistically it's the same as delivering something to a COPD population. But there isn't much evidence in post-TB lung disease. There was a systematic review. There was 7 RCTs that were reported, huge range of numbers, underpowered, huge variation in the time of the program. So it's a bit difficult to understand really what's going on. But again, just like pulmonary rehab, there's this need to identify what the clinical standards were. And of course, there's no getting away from assessing the patient. And this was a Delphi technique that was conducted back in, well, it would have been conducted in 2020 and reported in 2021. But it really identifies the importance of pulmonary rehabilitation, or the potential importance of rehabilitation. I think they were hoping there might be a bit more evidence, but nevertheless, those of us involved in pulmonary rehab are happy to go with it. One of the challenges was that we noticed in Uganda, and I don't know how relevant it is here, is that people, and I'm largely going to put physicians into this bracket, completely conflate pulmonary rehabilitation with chest physiotherapy. So I'm not going to ask for a show of hands, but there is an issue around that. And we developed this poster to really put up in respiratory clinics to help the respiratory physician and potential participants understand that pulmonary rehabilitation is not chest physiotherapy. So that's the other key message. No change in spirometry, and it's not chest physiotherapy. So we conducted a feasibility trial some time ago before we got the recharge money to show that pulmonary rehabilitation was feasible and acceptable. And recharge funded 2 fully powered randomized controlled trials in a post-TB lung disease population. So one was in Uganda and the second one was in Kyrgyzstan, culturally miles apart. So we offered very different rehabilitation, and you might be able to see the bottom right-hand one is from Kyrgyzstan, and they have this national dance called Karajol, I think. And I'm not going to demonstrate it, but there's an awful lot of shoulder movement and sort of dancing with hands on your hips. And to people in Kyrgyzstan, it was really important that we integrated that. The other really surprising thing that came out was volleyball, which none of us would ever have thought of integrating, but it's a younger population that have post-TB lung disease, and so sporting activities take on a particular importance. So you can see that there's some elements of this that look like a traditional rehabilitation program that I would feel comfortable with, and there are bits of it that I would not feel comfortable with at all. But actually, what was interesting was we had really high retention rates. And I think that's because we'd invested time with the population before we started to understand what good looked like. Now, I'm just going to share some results from our Uganda team, but we haven't published this yet, so you're going to have to pretend you've not seen this. And you can see that we got huge improvements in walking performance in the group that underwent pulmonary rehabilitation and nothing in the control. The control was flat. So we're really encouraged by this. And I think the other secondary thing that we don't see in COPD is this population, the average age was 45. So they are very keen to be economically active again. So we did some analysis on people's work productivity and return to work, and it was positive from that aspect as well. Not least because it's a younger population, but that's a benefit we don't necessarily associate with COPD rehab, where the population is a little bit older. So we're really encouraged by this. I'm carrying around the manuscript from Kyrgyzstan, and we're about to submit that, which looks as positive as this. And this is the data from Uganda. So, in summary, hopefully I've convinced you that pulmonary rehab is a high value intervention. The COVID-19 pandemic really highlighted the need to deliver different models, and we need further high quality trials to look at the best way of delivering, or different ways of delivering telehealth or alternative home-based models. Needs to develop further in low and middle income countries, and I think there's clear logic and guidance and growing evidence, I would say, for the delivery of rehabilitation in post-TB lung disease. Thank you.
We can take a couple of questions before we go to the next talk, and then we'll be having a panel anyway.
Thank you so much, Professor Sally Singh, for that talk. I have a question about retention of patients to complete a whole course of rehabilitation as recommended. What we sometimes noticed is that when patients actually start getting the benefit with the 6-minute walk distance increasing, there comes a point when they sometimes say that I'm already better. And that's a huge challenge, because you know they could potentially get better. Technically, they've achieved the minimal clinically significant distance, but they could be better. And how does one try and retain it? And is there anything that says, oh, it's okay if I stop at 8 weeks instead of 12?
I don't think we know the answer to that. I think it's a really interesting question, and years ago we looked at serial measurements of walking tests, and that's a burden within the context of a rehab program to do an additional measure every time somebody comes. But we found there was a rapid increase in performance very, very early on. Now that has to be psychological, that's not physiological, but if it works, you can't knock it. But they say 6 weeks to get, minimum to get a physiological training effect. And I think this is where we sort of end up in this conundrum with hybrid programs, because if people feel that they've gained enough, then it's difficult for us to argue against that. But there may be an opportunity for them to go on a home-based program, and then you follow them up. I think the important thing is, and we were saying this with the cardiac rehab, you need the data. Because the problem is if people just drift off, you don't know whether they've got the benefit or got fed up with it, or don't like the people in their group, or don't like the physio, So I think it is about asking people to come back and saying, can we do an exit assessment to understand where you're at? And I think that in our national audit, we're trying to collect data now for people that have this hybrid approach, and I think it's going to be really messy data to unravel. But there is, there are sort of economic evaluations for an individual. If they're coming to a centre, there comes a point where the trade-off is not worth it, and you have to respect that from the patient's point of view. If they feel that they are able to achieve their goals, then it's perhaps not up to us to say, well, we don't think you have. But I would encourage you just to get the measurements, so you just know, because patients will say, oh, we don't want to come to rehab because we don't want to park the car. That's all we get all the time. We can't park the car at your hospital, we hate coming. And I think that's just an excuse for we don't like it. Sometimes, they don't like a group. So I think there's real value in exploring other models. But I think that there is that trade-off for the patient, isn't there?
So I think one of the things the patients give us as feedback is one, that they feel the benefit is plateauing off, and
Yeah.
there's a level of boredom.
Yeah.
So sometimes it helps if we change the exercise
Yeah.
patterns around,
Yeah.
but it doesn't always work because the plateauing is what
Yeah.
they see that I
Yeah.
don't need to come into the center anymore.
So how long's your program?
I would advise 12 weeks.
Yeah, you see, ours is only 6 weeks, so we have a very different economic model in the UK. We have to do the shortest that we can get away with on a population level, so we don't tend to see this plateauing. Now, some people would argue that you need 6 weeks to get the gain, and then another 6 weeks, 3 months, to do the behaviour change. So, and I don't think we really know the answer, but I think that you should try and embed the behaviour change as you're going along, rather than, oh, you've done your 6 weeks, now what are we going to do? But ours is only, the UK is largely 6 weeks, and that's just because that's the least we can effectively get away with. But I think boredom would set in. Oh, and I get that. I think I'd be bored.
So usually it's 8 week a drop off. That's
Yeah. So I would shorten the programme. And then you can process more people. And the patients are telling you something, aren't they?
Yeah.
Hi. So this is a continuation what the query she raised. Probably we could not tell the patient that walking is not just the one criteria which has to increase. Probably we could give them some other criteria also when they talk about quality of life and strength and all those things. So not only telling that, if your distance improves and they tell us, okay, I can walk and we can discontinue.
So
Like.
a patient on the initial assessment is assessed by a... So the initial assessment actually has a whole questioning by the clinical psychologist and the physiotherapist and occupational therapist. So the patient sets their goals. So sometimes they're achieving it.
So can be a 360 degree. Can be a 360 degree.
Yeah, I take your point that maybe the patient is telling me and I can't shorten my goal.
Well, I think that's right. And you would process, economically, that would be more productive, wouldn't it?
Customize, the word customize
Yeah.
comes up very.
Hi, I'm Savita. I'm making a comment and not a question. Is that one of the things that seems to work with patients when we enroll them onto the pulmonary rehab is, I usually in my initial conversation I say, tell me 2 things that you're not able to do right now that you would like to do. Stair climbing is one of the most common things that they point out. If you've not added that into your little exercise program, you're not sure whether you've reached that kind of goal. And I've had people say, I need to get to the bazaar and pick up a bag of whatever and I can't come back because I get restless. So I put that into the exercises that I incorporate into them, and then we set goals for that. And normally, and then when they reach those 2 goals, you pick another one and say, what else would you like to do in your routine? You retain patients longer. So I think it's very self-driven. And the second thing I want to say, we do a lot. We've been doing with a couple of centers in Mumbai the hybrid models. Mumbai has a specific problem with traffic and a lot of this. So we tend to do the coming certain days of the week and this, and it's an option that they make. It's the second best thing from switching off from the program. And we also do now a lot more what people don't want, the educational sessions at the pulmonary rehab. So the last Saturday of the month. And often when we go on to those high...
on a treadmill doing stairs. So, I mean, it was chaos in the class, broadly, and was more cumbersome with staff. And we compared that with our conventional individually prescribed and progressed walking and resistance program, and there was no difference. So we pulled back from making it more complicated than we needed to, because there was no evidence that added value to the patient. And we were very sophisticated in how we asked and recorded their goals, and the patients reached their goals in an equivalent way in both groups. So it doesn't need to be that complicated. So I would encourage you to keep it simple, and that's what seems to have the benefit.
Yeah, Dr. Sari, that was an amazing quantum of work here. You have done across the different spectrum of the different parts of the world actually. So I would like to know what are the challenges you have come across in the Indian context of your work which you have done in the Pune as well as the other parts as well as in the Recharge project of Uganda. What are the challenges you have come across and how did you overcome all those challenges?
So I think the challenges can be divided up. I think there's one of the important parts of Recharge was to build research capacity. So it wasn't about us going in and doing the research. So we had to build research capacity in the teams. And I think that's challenging. You know, there was issues around blinding, doing all the measurements properly, you know, retaining, integrity of the trial. And that was particularly difficult during COVID. We got videos of the shuttle test going backwards and forwards to make sure our primary outcome measure was being done properly. And then there was all sorts of issues around data recording. So there are trial issues, which are probably of less concern to you today. Then there's the practical issues. Now, they broadly seem to be travel related. Wherever you go, it seems to be travel, whichever country you're in. I mean, it strikes me that India's particularly unlucky with travel, but, Uganda was quite grim in terms of getting around, so it's always travel. But I was in Uganda a couple of weeks ago, and they did a patient event for the post-TB trial, and we invited patients to come along to share the results of the trial with them, and we had patients travelling for 3 hours to come and share the results, and they travelled for 3 hours there and 3 hours back to take part in rehab. So I think for some people there is a real need, and they will, in terms of that, decision making, they are happy to sacrifice that time knowing that there is going to be a gain at the end. But I think on a practical level there's issues around referrals and people's awareness. So goes back to, you can have the best rehab program, but you have to get people in. We also did some work in Delhi, very specifically with an ILD population. So we developed a home-based written manual, not digital, but written manual for people with ILDs, which was positive. And then we worked in Jodhpur, in a very deprived community, so there was all sorts of challenges around that were almost insurmountable in terms of having a confirmed diagnosis of COPD, not being able to take any time off work because they were largely all manual labourers. So there were some real challenges in that population that I think we'd all guess, but it was really, really difficult. But I think travel is the big one. I think people are pretty willing once you explain it to them and advocate positively for rehab, but I think travel and accessibility, so that we can look at delivering rehab in community centres. It doesn't need to be in a posh gym with lots of exercise equipment, but you do need to have highly trained staff to do it, because if your staff are frightened of people getting breathless, you can guarantee the patients are frightened of getting breathless, so it doesn't sort of go anywhere. So I think staff training is really key.
Great, I think in the interest of time, can we move on and take questions from the panelists? No, Samir, okay.
Thanks, Professor Singh. So one question I have is, when you decide that the patient should go for a maintenance phase, because everyone says, okay, 6 to 12 weeks of the program. So do you have some sort of predefined goals that, okay, if my patient achieves, say, an improvement of 60 meters on a 6-minute walk test or something of that sort, or just a health-related quality of life questionnaire shows an improvement, then is when you decide. So any specific targets for some?
For maintenance?
Yes.
No, only in as much as the term is maintain and not necessarily improve. So I think the key is to so if you, the sort of classic randomised controlled trial was conducted in the UK, 6 weeks of rehab against a control and no intervention at follow-up. And then obviously the rehab group got better, the control group didn't, and then the control group got way worse and the rehab group got a bit worse. So at the end of 12 months, there was still a big difference in the groups because they both declined. So the challenge of maintenance, trying to maintain somebody's behaviour is really difficult, and there have been lots of different strategies tried. We've just finished a trial where we looked at using a manual and community-based group sessions over a 6-month period, and then did the analysis at 12 months. And there was improvements in people's EQ5D, which is their health-related quality of life. Exercise in both groups stayed the same, which is really baffling. But the health economists are really excited about it, and NHSE are quite excited about it, because we saved. So the burden on the general practitioner was much less. So we're about to publish that as well, but the health economists were way more excited about the results than I was, which is not a bad thing.
Well, thank you so much. I think
pleasure.
It's excellent discussion, and I'm sure there's many more, but we can take some more in the panel discussion. Thank you so much, Dr. Singh. We invite Yogita, the head of cardiopulmonary rehab at Vayu Chest and Sleep Center, to present her findings of the local perspective in addition to whatever was already being touched on.
Good evening, everyone. This is a pleasure having all of you here and presenting my lung and heart together. So when I say this topic is very close to my heart, definitely it is something which we say it's heart connecting to the lung, right? So thank you, Dr. Sally, for her valuable insights, and hopefully we have understood a lot about pulmonary rehab and global and the local issues, and how we are going to put our major foot forth to understand what we are coming up with, right? So local perspective is something under the pulmonary rehabilitation I'll be taking away today as a topic, which really we need to understand what exactly in this perspective we are going to practice as in healthcare professionals. So when we talk about the healthcare professionals, we all are here from the different point of spectrum. So when we talk about the different point of spectrum, we have a pulmonologist here, we have the respiratory therapist, physiotherapist. So we all are here to understand the critical aspects of a complete care, or a critical aspect of a complete care about our patients who are really suffering with chronic respiratory diseases for their life. I can say something which is really bothering us when they communicate to us, when they come to discuss about their lifestyle, their daily livings and the sufferings. So let's participate in that and take something out of today's discussion and make the best out of it and do something good for our patients. So it's not changing. Yes. So quick glance to the contents which I'll be discussing today. The current state of pulmonary rehabilitation in Bangalore, India. No, it's not coming. Let it be. Let it be. Let it be. Yeah. Yes, sir.
Excuse me, sir. So can you help me to do the mirror display?
Yeah, but you can see it.
So it's in working there.
Can you just move the next slide? You may be able to see it on the YouTube. You're checking here.
And this is not working deep.
It's got stuck there.
I'll repeat it.
Just go to the. Where's it gone now?
They are trying to mirror it.
No, don't forget the mirror. Just go back to the presentation.
Yeah.
Okay, just leave it. Let me just play with it. Just go from here only. Forget it. It's mirroring and it'll be cool. It's not moving. The problem is it's. Okay.
Huh.
Wait, let me work it. Okay, let's go with this and see.
Yeah.
It's on. Good.
Yes. So, quick glance to the contents which we will be discussing today. The current state of pulmonary rehabilitation, Bangalore, India. The scientific underpinnings, which we will definitely discuss about the guidelines available. The 1 year work done in pulmonary rehabilitation by Team Vayu, and what can be done as in different, or what are the measures which we can take ahead. And our call to the community, it's something which we will be talking about the levels at what are the policies, and PR out of the box and moving forward, the summary, and there is a small video which will be playing here for the holistic management, which really interesting video to look into. So there is a question which I pose to discuss or share with. Definitely we have answers for these questions ahead. So what are the current state of PR in India, and is it something which is making it difficult? Is what the availability, the practice or the implementation of PR, or don't we have enough cases to refer for pulmonary rehab? And if it's yes, and there is a lot of chronic respiratory disease burden which Dr. Sally has rightly shared with us in complete, I can say, low income countries, the data is available. So why we are lagging behind? So to take it ahead, I'll just try to have some scientific data available within the population in India. So there is 32% of the global burden which India is having as the global burden 2020 report, and which really is a significant public health challenge. So we need to understand there are a lot of cases, but what are the challenges? Definitely we will be discussing further. In a recent report in Economic Times, Dr. Sudeep Sardi, he is from Pune, and I guess ma'am has worked with his team again. So he has also highlighted that COPD will be soon a capital. India will be a capital for the COPD conditions. So this again gives us a definite, I can say, challenge to understand we have enough cases. So talking about the current state of pulmonary rehabilitation in Bangalore, India, there are a lot of studies done. So in Indian, the concept of pulmonary rehab is been in culture in 1990s, but something which post COVID is what we all have seen it as a platform where all the patients also started having an awareness, and it's again still not being in a complete, I can say, full-fledged availability of the system or the implementation or the practice of rehab. Further, we talk about the practice. Definitely where is the implementation of pulmonary rehab? So in India, definitely the pulmonary rehabilitation implementation is still at its infancy, and really it's surprising to all of us. And what is going wrong? So maybe only a few isolated clinicians or the researchers are delivering the data and practicing pulmonary rehab in their own setup, and mostly to highlight most of the data are from the metropolitan cities, we say Pune, we say Mumbai or Bangalore. So something which we again have to look into, what about the rural population, and something which we talk about the population, they don't even know about what is pulmonary rehab, right? So these are the areas again we could try to highlight and do a major research on. Availability. So again, so this is the question which we were trying to highlight here. Even in the developed countries or the nations, the estimated availability of pulmonary rehab programs is that it's 50%. So what is in Indian context is, it's again really poor and bad. Apart from the metropolitan cities and few centers and the clinicians practicing, it's again very poor. So what are the challenges, barriers and gaps for implementing pulmonary rehabilitation in India? We have few levels to discuss, and one of our senior, Dr. Maria Gianandani and Dr. Agrawal, there are few studies done by them which they clearly state about the challenges at these levels. National level is something which we will definitely try to look into what the governing bodies can do. It's nothing which we can help into much. So there are lot of, like I can say, accessibility issues on the PR services, and structured policies need to build. At the community level, definitely we as a team, again we are trying our level best to create a lot of awareness, doing a lot of, I can say, patient communication or sessions, and some projects which will definitely create a major awareness. And underdeveloped physical and social infrastructure. So as Dr. Sally has rightly said, there is nothing to have centers or something. Searching for the delivery models, start right away. The moment we see the patients are indicated for pulmonary rehabilitation, let's do it. At the clinician level, policy issues, so there's policy issues, so there's something which the makers can help us in that. Societal and cultural factors, again we say that family members have already seen the guidelines and the evidences, so we not go into much detail with that. So there is level A evidence by the GOLD report for pulmonary rehabilitation, and with the ATS society they have given the documents or the guidelines or the statements which really have a strong, I can say, recommendation. There's something which we would like to highlight with the comorbid condition or with a diagnosis again, a combination of COPD with the PH, pulmonary hypertension. So this is something again, Dr. Prerna has joined us, so she is also practicing cardiac rehab in combination. We are doing a lot of cardiac and pulmonary. You can see in every 6 sessions to 12 to 18. So this is how we try to see the outcomes improved in the patients under the aerobic capacity or their symptoms or the quality of life. The disease dynamics which have a lot, I can say. The refer to enrollment to the assessment is something which we found. Difference, but it's not that bad. It's close to 80 to 71 or 60%, which definitely it's a good number. The community events, what we have done, trying to create an awareness in the patients and sharing their comments or their, I can say, comfort which they have shared with us is really interesting to know. Many of the patients say that, yeah, my family members started participating in their own physical activities and lifestyle changes they have started doing in them. There's something which we have found interesting. So let's do more of awareness events. So recently we have done World Heart Day and Pulmonary Fibrosis Awareness on 29th October 2024. And there was a good feedback from the patients too. So here is a glimpse of that. And yes, so far what are the challenges and the growth? If there are challenges, definitely there are strategies, and Dr. Mehta and Dr. Sameer and Anmol, we have a team of members who definitely push us and support us, and we keep making a lot of discussions on the strategies, what can be the best for the processes and what could be the best for the patient care. So we may have n number of lists for the challenges in terms of economics, adherence and comorbidities and so on, but what are the differences which we are trying to make in putting some better strategies to improve the patient care? So we definitely have the hybrid delivery model, which we call it as an online, on-site, at home, or a combination of all of. So what are the individual tailored practice or programs? So we have a lot of discussions after Dr. Sally's presentation, where the complete panel was discussing a lot about maintenance phase or something, where they're talking about what could be the outcomes improved, what could be the number of average sessions or minimum sessions the patient should enroll. Is something again we talk about is a customized tailored program. Not one patient will have the same reflecting problem list. So different problem lists, we have different approach, we have different protocol, different treatment management, and I can see the difference and the variations in their outcomes as well. So it takes a lot of efforts to see a patient to patient. It's major difference we have to see. It's not like every COPD will have the same reflecting symptoms or reflecting impact on their life. We also work a lot about the patient education materials, whether it will be some kind of brochures we create, and we keep discussing with them. A lot of diagrams and flowcharts are being done by our team, and we put a lot of efforts in explaining the patients. So this is something which we need to understand and target about. Integrated psychological evaluation definitely will help in the adherence issues. When we talk about the low adherence in the patient or the maintenance phase, it really helps for getting a psychological evaluation, and let's push the patient further. So we have our multidisciplinary team working on it. We definitely put the patient into a personalized program or a personalized or customized care program. And just added about the integrated cardiac pulmonary rehab program to see that any comorbid condition coming with PH is also managed well. These are the success stories. I've just highlighted 3 of our case which we have shown differences. We have just added few pointers where we have seen what outcomes are achieved with what number of sessions here. So when we talk about a 40-year-old with a case of sarcoidosis, she always used to complain about the chest tightness. So what could be the reason, or what are the problems, and how the rehab approach has to be completely different. So we started doing some kind of stress relaxation techniques with her. We also tried some better postural corrections or spine mobility training. So these are some different approaches we are putting efforts in. And what are the outcomes which we see? Major minimum to minimum 8 sessions, we have seen difference in our patients' outcomes. We have seen improvement in their quality life or a sleep quality or something with the exercise capacity, and reducing stress. Majorly the patients are into a stressful life when they feel that okay, this is something which is bothering me for lifelong. Am I going to come out of this, yes or no? And the next case which we have seen is an obstructive sleep apnea. So we again have a specialized specialty clinics where we work on the patients who have ILD with a combination, or a COPD with a combination of obstructive sleep apnea and some postural issues which can be managed well with some difference and changes in their protocol. And definitely the problem list can be improvised. Yeah. Then we also have patients, a lot of numbers which I have seen the trend of ILD is the major number in our outcome. So that's also major number of sessions, and continuation of the maintenance phase is what we have seen improvements in the patient. So most interesting what will be the today's takeaway. What more can be done in Bangalore, Karnataka and India, and what are the easy measures to see we achieve all this? Awareness is a key. Definitely we all say it's something which we need to work on. So at all the levels of interactions, we need to put efforts with discussing with the pulmonologists, physicians, ICU doctors and the general physicians to see there is an initial engagement from the hospital care itself. Patient at large, individual, media or any specific organized events which can keep enhancing or improvising the awareness. Help providers to educate and refer. So when we talk about the providers, we definitely can see a game changer where not only the meds can work, but there is better, more things which we can achieve from pulmonary rehab. Refer to the appropriate centers. So so we talk about something which definitely we need to empower our patients with a lot of technology involved in that. So something which we talk is what the policy makers and the societies can help us in this. And again, Dr. Maria Gianandani recently in her article she has highlighted from Mumbai what are the societies and organizations doing to improve pulmonary rehab and its implementation. So this is something which we definitely request. Out of the box, which we try to improvise our program for every patient care will be personalized treatment plan and a complete data and documentation to see after 1 year to 2 years what are the changes which we are putting efforts and what are the articles which we can publish or some better research which we can highlight. Multidisciplinary approaches which will definitely improve the patient as personalized care program. Motivation and engagement is a highlight again here to see that patients are self-empowered to manage their own or try to take care of their own symptoms. Remote monitoring, adding to the delivery models, so we try to choose the best what model which suits the patient. Exacerbation tracking, again it's really important to make the patient understand how to track their exacerbation when they are going to review their doctors, what happens next. So these are something which we need to put in as efforts in the complete technological aspect. So we all need to empower ourselves again with the technology, how it can help. So there are a lot of applications or web applications which motivate the patients to undergo the complete plan. There is a short video we have, if we have time we'll try to play that video. It's mostly talking about the holistical management, and the summary we have to take away today will be pulmonary rehab is well timely tested and well proven strategy. What is the new thing which we are adding here to understand the local perspective which we have so far discussed? With the disease burden, pollution and longevity rising assumes like the tremendous importance of pulmonary rehab, and we have already added about cardiac and the integrated approach. As a community we need to rise to the occasion to help our patients is something which we would like to highlight here. And better, more rehab centers we need to get in our own city to see the patients have been taken care with the maximum need they have. Thank you all. Any questions?
I think we take the panel discussion now. 15 minutes.
Sure. Yes.
Word of appreciation for you, Yogita, and Mohan, all of you at Vayu for the amazing work that you're doing. I think we're very fortunate as Bangalore with more and more pulmonary rehabilitation centers opening across the city. There was a time when the only person I could refer patients to was Dr. M.D. Chandrasekhar from Pulmonary Jain, and that was the first program that started. But now we have centers in Jayanagar, in Rajajeshwari Nagar, Sakra, Dr. Sachin has a unit. So with more centers opening across the city, as you said, your last point, we need more capable centers, the travel and traffic problem gets solved. And as we start collaborating, it might be my patient, but if they live closer to Jayanagar, they're definitely coming to you, Yogita.
Yes, thank you.
Thank you. Thank you so much. Thanks, Yogita, for the presentation.
Thank you, sir.
We have around 15 minutes exceeding legitimate time where we can take a few questions. Dr. Sally Singh, can you join us there? Dr. Satish? Dr. Sandeepa? And we'll take anybody from the audience. Dr. Ramesh, Rajni, all are there, but in the interest of chair space, we'll take 3 guests over here. So, please sit, please. So, just a few, is there any questions from the audience you'd like to pose to them? Otherwise, we'll take up a few interesting points. Okay, so one thing Dr. Sally Singh you mentioned was very interesting, that one thing you mentioned was very interesting is that you can do rehab at any stage of the disease, and you showed some lovely examples. On the other hand, the adage has always been, when we picked up on this, on the understanding is that optimize the disease to get the best impact of rehab. How do you reconcile those two aims? Because we're seeing a lot of these patients. I mean, if you, and my colleagues will agree, this winter is being a particularly harsh and bad winter. Every virus who went on a holiday in COVID has come back. We've seen a tremendous amount of admissions. We've seen a lot of comorbidities, and the readmission risk is very high. But at the same time, optimizing them, sending to rehab, the timing seems to be a question. So this is one thing which I wanted to ask you particularly. Go early at an improvement stage of disease, or wait for them to get better and accelerate the process.
Lots of questions rolled into one there, weren't there? So
I tend to do that.
So there is an argument that I don't think has been particularly well tested, that you can use rehabilitation as a preventative strategy in mild disease, but we tend to focus when we're providing a service on the more severe patients. So I think there's a research opportunity there. What I'm not sure about is whether rehabilitation in its current format is particularly attractive to people with mild disease, and then you need to follow these people up for a long time to see if it is, does it have a preventative element in terms of disease progression. In terms of post-exacerbation rehab, NICE in the UK, and the data would support this, is that rehabilitation should be offered within the first 4 weeks post-discharge. Now there are readmission gains around that, so if you get people early, then you hopefully prevent them from readmitting, because once you've had one admission, your chance of having a second readmission escalates. Getting people to do rehab immediately after an exacerbation is a real challenge, and it's a real hard sell. And I suspect that's where there'll be some opportunities around alternative models of delivery, because I suspect post-exat patients don't want to leave home particularly, or there may be a sort of hybrid model. There's been all sorts of strategies that have been looked at to try and help people come to rehab, showing people videos or having taster sessions. Nothing really works. So I think that, again, in terms of research, the field is absolutely wide open. But I think if you can optimise pharmaceutical management, that is ideal. And I appreciate that in a lot of low and middle income countries, what the World Health Organization would identify as sort of minimum availability of inhalers, for example. When we work in Africa, people just can't get them. So we can say as much as we like people should be on triple therapy, but it's not going to happen. So I think you have to be pragmatic and offer rehabilitation as a low-cost intervention when you can.
Sounds interesting. Dr. Satish, 35 or 40 years UK to India. What do you think are the main challenges from an Indian perspective? Take-home messages. How do you push, promote, and promulgate rehab with all the right intentions?
Ravi, I think as our Yogita was presenting the challenges, the same challenges continues to be there with all of us, especially referring physicians. Mainly, many of them are old, elderly, and they don't have anybody to take them to rehab places. They are looking for alternative, but motivating them really helps. But I spend a lot of time saying, you have to do it. And now I have found many places, east, west, north, south. I have friends here who are all sitting here, and then I choose one of them. They're all really good, and sending them to these places. But talking to them, Ravi, is really helping, motivating them, spending about 5-10 minutes with them. This is it. You have a COPD, and the next treatment is only a rehab. And giving them several examples of my own patients who have come back happy and strong, and has helped them. And what I found is there are many, home-based kind of, I won't call it a rehab. There are some exercises which are there, which are done, completely not structured, unscientific. But patients have found a little bit benefit, so I push them saying, you go to the place, you meet other people, and you will reap the benefit of it. So it is for the referral doctor, as I think you showed one of the slides, that how the referral the specialist knows about the rehab, and the advantage of rehab that he knows, and then he has seen himself coming back from the patient. That really helps. And it's on all diseases. I think my own feeling is that I'm not referring many patients with post-tuberculosis. I presume that they are going to be like this, but I think I should do more. And as you showed, and especially from Africa, and Yogita also showed a couple of patients. But even the gold guidelines mentions about rehab, oxygen, and showing that these improve quality of life and survival. I think that the challenges are many, but I think it's up to us, for us to motivate patients to go and do the rehab. And I get good feedback from all the referral center. That helps me to learn more about it and to motivate more patients to go and do the rehab. That's how I look at it.
Excellent, thank you so much. Sandeep, you worked in St. John's, a mecca and huge volume. So that low middle income group of which Dr. Singh spoke about is so profound there. Then you come into private practice over here. Challenges you would like to give some take-home lessons. Question number one, and I do this often. So question number two is that this interdisciplinary part, getting a nutritionist, a respiratory therapist, and the rehab person together, it seems to be a big challenge in our setups. Any thoughts on all this to make this more effective?
Definitely, sir. As you said, even in a place like St. John's, we never had a dedicated pulmonary rehab thing going on. As long as I was there, I don't know what has happened now. As you said, in our setup, it is very, very difficult to get all those people on board for one particular dedicated program, because there is definitely lack of resources. There is no doubt about it. And I think there are hardly few rehabilitation specialists. Of late only, Yogita and few other people have come up. There are hardly any rehabilitation specialists who can dedicate their time to set up the, proper rehab center. If it were to be pulmonologists only taking the center stage, taking the lead and organizing everybody, I think most of us will be busy with our clinical practice rather than this. Those are all the challenges. I think I heard Yogita, I wanted to tell you. See, you are seeing two stalwarts. I think sir has gone to many physician conferences to tell people about asthma and how to treat it. And sir has gone to many conferences telling about interventions, and you see both of them standing here where they are today. I think disease, but at least I think making the people, the patients able to carry out their day-to-day activities with minimal exercises is the only thing which we can offer. I'm sure most of the pulmonologists will agree, and eventually things will fall into place with more number of rehabilitation specialists coming in, more clinics or more centers opening up. Definitely rehab is going to take the lead.
No, thanks. We have 12 million people, 3 New Zealands, and we have 4 rehab centers, 3 of which are represented by their...
That is the thing. That is the thing. I think as the number of specialists increase,
Singh, back to you. Sorry, Satish.
Just going to say that, those who are doing now, they must encourage more people to come into rehab.
Yes.
And, have more places so we can send. I get feedback regularly from Yogita, Veena, and also from Sparsh. I get regular feedback, various graphs that I get to see them on my mobile, on my mail, and which helps me also to know about how patients are doing. That's very important. So when you start sending these, recording of how patients are doing, so it also helps us to learn more about rehab and also motivate more patients to go and do the rehab. I really feel like many patients after post-COVID who have absolutely no objective measurement of any defect continue to have fatigue and things like that. I don't have any medicine. I tell them, you go and do rehab, and that will help you. And I'm sure many of them are benefited with the long COVID, post-COVID, fatigue and lethargy and those, areas. I think there are many areas which needs to be explored.
Right, Dr. Singh, back to you. So we had an observation from January of this year up to September. There was a report saying that our vehicular population has tripled. The economy boomed in India. Other parts of the world are not doing so well. Presidential issues. And we bought lots of vehicles. We increased our AQI. Our pollution is at all-time high, and traffic has tripled in cities like Bangalore, with the average speed slowing down this year around 3 to 4 minutes per kilometer. In the midst of this, patients decided their pathway. The traffic part, which we also call the 3 T's, time, traffic, travel, came as an impediment. They'd rather give up on disease improvement than do this, and we empathize with them because we know the travel onerousness. So now suddenly practice has jumped data, where any model which works is being followed now. How can we serve you? Is it home? Do we do hybrid? Do we do pure online? Or do we center-based? Though we push center-based, we have realized the challenges. Because the practical part is going up, and again we were trying to form a model to study this, and you'll be talking more tomorrow. How do we look at this? Do we just go on?
So we've been pondering, I think trial design is really key. I sort of alluded earlier that a conventional randomised controlled trial doesn't work particularly. So we've just finished a trial in long COVID, which was positive in terms of fatigue and exercise capacity. But for that model, we had, so I'm telling you about it because we had a centre-based model and a digital platform. So at the point of randomisation, we asked patients whether they could do digital or do centre. Now, if they couldn't do a digital programme, they were automatically allocated to the centre-based arm and randomised in that arm. If they could do digital, they went down the digital arm and were randomised in the digital arm. So we had both interventions compared to a control. The problem when you do these equivalence trials, which is what I was trying to show earlier on, is that when you do a randomised control trial, you have to assume that patients are willing and able to accept either intervention. So they would be happy with either centre-based or home-based. And the problem is, like most of us, we have a preference as to where we'd rather go. So that becomes a problem because you're then forcing a patient to arguably do something that they wouldn't choose. So I think we're exploring things like platform trials where patients can have a choice and you can move on from an intervention if it's failed and test another intervention. But I think we need to be more sophisticated in how we design the trial. So NICE, who govern how we spend our health budget in the UK, have asked for more anyway, so there may be some value in doing that, or our other approach is to use real world data. So we have a vast amount of data in our pulmonary rehab national audit, so we can match people on certain characteristics. But it is trial design is a problem for these alternative interventions, and I think the thing is, I suspect all 4 centres here have 4 completely different approaches, and it all becomes a bit random as to what's working and what isn't working, and what are the characteristics of the patients where home-based works or digital works or video conferencing works. I don't think we know. And I think that, it's an exciting time in a way, but there is a lot of work to be done really in that space.
And it's a moving target right now. As the world changed around us, providing healthcare delivery is becoming a challenge.
It's a nightmare. The trial process cannot keep up with digital technology. So, in the UK, we apply for money, and sort of 6 months later they'll say yes, yes or no, you got it. Let's say yes, you got it. It'll take another 6 to 8 months for all the contracts to be signed, by which time it's a year before you've even seen a penny of the money and you've written an ethics form. So by which stage technology's moved on and we're all wearing headsets and doing virtual reality. Or so, I don't know what's around the corner, but we cannot keep up with the changing technology at the moment. I suspect we don't need to make it too difficult. So the app that I showed you earlier for COPD that was integrated with yoga that seems to work well. The next piece of work we're doing currently is adapting that for a post-TB lung disease population because they are younger. I suspect they are much more digitally literate than a COPD population. So our next trial will be testing that app in a post-TB population. So who knows? I'll let you know this time next year whether it worked or not.
Absolutely. 1.5 billion people in India with all sorts of problems waiting for this to happen. Okay, I think it's been a lovely program. We'll take closing comments, 1 minute each. Dr. Sandeepa, any closing comments?
I think rehab is something which is very much underutilized, I think, at this juncture, in our country at least. I think creating more awareness and setting up more centers and reachable centers and policy makers getting involved are the only things which will take it forward.
Now the WHO has put it on their...
Yeah. I think I recently saw a newspaper cutting.
Every conference has something about rehab, which is great. Earlier we used to have probably on the last day something about rehab, and very few people used to be there. And I think that will help. Every conference now is having this. And hopefully in the future there will be a rehab conference, where, people will go. I remember attending a conference on drug toxicity in HIV. Only toxicity is spoken, world conference. So similarly, hopefully there will be something on rehab, and probably we'll also have rehab specialists in COPD, rehab specialists in ILD, rehab specialists in post-TB and whatnot. And that really will help, as Dr. Sally was saying about, the technology, and is so much that, it's difficult to catch up with that. And hopefully that will help us in delivering this rehab to patients and making really impactful life on their disease.
Great product, lovely, need tremendous, delivery a problem. Dr. Sally, seeing your last your comments on this to wind up?
Well, I completely agree with everything you both said. I guess one of my challenges would be around data collection, and are all 4 centres collecting the same data to allow you to make comparisons? So I think there's something about a minimum data set that allows you to develop the evidence around rehabilitation, and I think that's a fair in some ways. My second point is that despite all of these other models that are being developed, which I think is great, you absolutely have to have that initial assessment. You cannot move away to just people coming into your clinic and saying, let me put this app on your phone. Exercise is medicine, and we have to treat it with due respect to get the best out of rehab for a patient.
Thank you so much. Any comments from the audience? Would you make some final comments? The mic to her, please.
I think we should like to think that we have begun in India now. I think we have 2 years society. Yeah, we have a society of cardiovascular pulmonary physical therapists. It came out of Mumbai, and you have more than 300 physical therapy professionals. who are practicing in cardiac rehab and pulmonary rehab. And we meet regularly, we do updates, we do advocacy, and we've begun the journey, and cross our fingers that people from Bangalore will join, because a lot of online events happen over there, and everything that's new. We also have started funding and research initiatives from the society. So just to inform that there is something going, and so there is light at the end of the tunnel.
Okay, excellent. On that encouraging note, I think we'll call it a day. Again, thanks a lot to starting with all of you who have come, and so many people online in bits and pieces who've logged on everywhere. Thanks to Dr. Sally Singh for making it over here. I think we've kept her extraordinarily busy, and I hope it's been productive. But we will not underestimate your impact in trying to make a difference, and that too among the cardiologists. I would put that on absolutely top notch. Dr. Satish, Dr. Sandeepa, thank you so much. Thanks to Dr. Swami to arrange all this stuff, and our gratitude to our sponsors, who basically are pharma sponsors, but are now seeing a very important product being talked about with so much enthusiasm, and hopefully will make more inroads. As she just said, 300 docs, 1.5 billion. Look at the ratios. We have a long way to go. So, sorry? Yeah. So anyway, so the customary book is, Swami, please go ahead. Yeah. So all of you online, thank you so much. We're doing a pleasantries. You can log off anytime you want. Thank you so much. We wonder how you're going to take that to Coimbatore and to the UK. Yeah. Dr. Satish and Dr. Sandeepa. So as we chew the card on rehab, it's time to have some real dinner. Thanks. Thank you so much. Very well done. Take one flop for your wife. She's there for make her happy.
Wonderful speakers.
All done.
Wonderful closing.
Good.